Hi, I am Senior Staff Nurse Pauline and my colleague Senior Dietitian Shalene. We are from Changi General Hospital and will be sharing about post-stroke nutrition, screening and intervention for stroke patients. We will be touching on the factors that affect nutritional status in post-stroke patients, nutritional screening, assessment, and intervention. Stroke is the fourth major cause of death and disability. Nutrition is one of the key elements of stroke management. Malnutrition or risk of malnutrition increased significantly during hospital stay from 9% to 65% in acute stroke patients. Other stroke-related symptoms that affect nutritional status include decreased motor function, dysphagia, decreased sensory function, perceptual and visual field defects, disturbed level of consciousness, depression, poor oral hygiene, cognitive deficit, reduced mobility, and constipation. Malnutrition affects the clinical course of stroke patients. Compared with nourished patients, malnourished patients need longer hospitalization stay, have an increased rate of complications such as infection, pressure ulcer, fall, and an increased frequency of dysphagia, slowing down the process of wound healing and compromising immunity function. Proper assessment and early management is vital to reduce the morbidity and mortality. Nurses looking after stroke patients should be vigilant in monitoring and report any complications such as infection, signs of dehydration, and malnutrition.
Next, we'll talk about nutrition screening and assessment in stroke patients. First step of nutrition screening is to identify the patients who are at risk for nutrition problems or who have undetected malnutrition. It allows for prevention of nutrition-related problems when risks are identified and early intervention when problems are confirmed. Patients who are admitted to hospital should be screened within 24 to 48 hours upon admission. This is so if patients who are at risk of malnutrition or malnourished can be referred to dietitians for timely nutrition assessment and intervention. Some common validated nutrition screening and assessment tools that is available are Malnutrition Universal Screening Tool or screening tools that are developed by various hospitals. Nutrition assessment is more comprehensive than nutrition screening and are done by dietitians. It is the comprehensive evaluation that dietitians do to define a person's nutrition status and to monitor the changes. Information is gathered through A, B, C, D format. It includes anthropometric measurements, biochemical results, clinical examination, and diet history. I will elaborate more on each component in more details in the next few slides. First step to a nutrition assessment is to obtain the patient's height and the weight. From there, we can calculate the BMI, which is the body mass index. It is recommended to monitor the patient's weight upon admission and weekly. If the weight is not able to be obtained for some reasons, because patient is not fit to be weighed, a mid-arm circumference and skin fold thickness can be done. Second step to a nutrition assessment is to look at the biochemical results. As we know that high cholesterol and diabetes are the risk factor for stroke, it is important to look at the lipid profile, fasting glucose, and also the HbA1c. High blood sugar during acute stroke will affect recovery and clinical outcome. It is important to monitor the random blood sugar level and ensure the blood sugar is optimized. It is also important to look at the trend of the blood results such as renal panel, hepatic protein levels, as this may tell us if patient is dehydrated or may need more protein. Albumin is not a good indicator to determine the nutritional status as it may be affected by various factors. The third step of a nutrition assessment is by looking at the clinical aspects. To take into consideration of patient's past medical history, physical examination to determine if patient is at risk of malnutrition or patients who are malnourished. Memory and cognition is also important as this may affect patients' oral intake, which may attribute to poor intake or overeating for patients who have forgotten they have eaten. The presence of wound pressure sores may mean patient has increased protein needs and may need multivitamins, zinc, vitamin C to speed up wound healing. Taking a diet history is also important as it allows dietitians to find out the pre-morbid oral intake of the patient. In this way, we can see if patient is eating adequately prior to admission. Looking at the input and output chart, which is often done by the nursing staff, is important as it usually has the following information: amount of fluids taken, the portion of the patient's meal taken, amount of oral supplements, and the types of high-protein snacks taken. It is a tool to help us to see the types of food patient eats, especially if they eat outside food, as well as the quantity of the food taken. Amount of fluids taken is also important as low intake of fluids may lead to dehydration. Patients who are usually on thickened fluids may not often meet their fluid requirements.
Some tools to monitor patients' nutritional status are: monitor the weight upon admission and weekly weigh with a chair or standing scale, or hoist or bed scale, making sure the scale has been zeroed before use. Input and output chart, charting the amount of food taken including high protein snacks or oral supplements will need to be indicated in the IO chart. Checking on the vitals regularly, as well as the ability of patients being able to swallow and determine the risk of aspiration. On the other hand, dietitian will do the physical assessment of the patient to see if there are any loss of muscle, fats, presence of edema. Presence of edema may sometimes mask the weight loss. Looking at the trend of the renal panel and hepatic protein level, as this may indicate if patient is dehydrated or may need more protein respectively. Assessing patient's intake based on the IO chart, and also asking patients or family regarding food intake and acceptance of high-protein snacks or oral supplements. Information are gathered using A, B, C, D format. Next, we will touch on nutrition intervention. Why is medical nutrition therapy important? Proper nutrition will help to minimize body's protein catabolism and enhance muscle protein synthesis. Therefore, it helps to increase muscle mass, prevent muscle wasting, and improve immune system. Study has shown that patients get less depressed and more motivated to participate in rehabilitation with medical nutrition therapy.
Estimated energy requirements can be calculated using Schofield's equation, Harris-Benedict, or the quick method, which is 20 to 30 kilocalories per kilogram body weight. If a patient is obese, BMI of more than 27.5 kg per meter square, adjusted body weight will be used. To calculate protein requirements, we use 1 to 1.5 grams per kilogram body weight per day. Stroke patients will have higher protein requirements to prevent infection, muscle wasting, pressure sores. Thus, it is recommended to use 1 to 1.5 grams protein per kilogram body weight per day, unless it is contraindicated with patients' medical condition such as chronic kidney disease on conservative management, or other medical conditions which does not allow patients to have excessive protein intake. To calculate fluid requirements, we can use 25 to 30 ml per kilogram body weight or 1 meal per calorie required. That is, if patients need 1005 calories, they will most likely need 1005 ml fluids per day, unless contraindicated.
Enteral feeding is recommended when patient is not able to take food orally, and it is feeding the patient using a nutritionally complete formula via a feeding tube. Tube feeding can reverse malnutrition. Most stroke patients doesn't require long-term tube feeding. Research has shown 65% of patients resume full oral intake prior to discharge. Start of early tube feeding less than or equal 7 days may decrease the risk of death by 5.8% and decrease in death or poor outcome by 1.2%. It is advisable to start early tube feeding if gut is functional and no other contraindications.
Oral supplements is used when a patient is not able to meet nutritional requirements based on dietary intake alone. It is a nutritionally complete nutrition product. Oral supplements is usually based on patient's medical condition, preference for oral supplements, thus this will ensure and encourage patients to take it. It will help in increasing nutritional intake, which improve nutritional parameters, but not necessarily functional outcomes. For patients who dislike oral supplements, fortification of diet is another approach. Fortification of diet is to add one or more ingredients to a diet or provide high-protein, high-calorie snacks to help increase calorie and protein intake, which can help patients to meet nutritional requirements. Some ways to fortify diet is to provide high-protein, high-calorie snacks such as sandwiches, yogurt, or pudding. To help increase taste of food, sesame oil, cut chili, or soy sauce can also be provided. Extra gravy or sauce can also help increase calorie intake.
Close monitoring of patients' nutritional status is vital. Continue to use the various nutritional tools available to monitor the progress of the patient. Timely communicate with the multidisciplinary team for the latest update plans for the patient. And lastly, to adjust the nutritional plans and intervention based on the patient's needs. Take-home message. All patients should be screened for nutritional status. Good nutritional support is important to ensure optimal recovery for stroke patients. Nutritional supplementation is beneficial for patients with poor or deteriorating nutritional status, and ongoing nutritional monitoring is important to ensure optimal outcome. Thank you.